Assalamu alaikum, Dr. Bushra here. Today our topic is arterial supply of heart. So arterial supply of heart is also called coronary circulation. Heart receives its blood supply from two coronary arteries, that is right coronary artery and left coronary artery. They both arise from aorta, that is ascending aorta, near the point where the aorta and left ventricle meet. They actually arise from the aortic sinuses, which are the dilatations or cup-shaped structures just above the aortic valve. These arteries and their branches, they supply all parts of the heart muscle with blood. So first we'll talk about the right coronary artery. Right coronary artery is the smaller of the two. It arises from the anterior aortic sinus of ascending aorta, or also called right aortic sinus. It descends in the right AV groove and sends branches to right atrium and ventricle, and it ends by anastomosing with the left coronary artery in the posterior interventricular groove. So, what are aortic sinuses? Aortic sinuses are the small pocket-like expansions at the base of aorta that give rise to the left and right coronary arteries. Here you can see these are the aortic sinuses just above the aortic valve or the orifice of aorta. So these are three in number, that is right, left, and posterior. Right coronary artery arises from the right aortic sinus, left arises from the left aortic sinus, and there is nothing which arises from the posterior aortic sinus. Here you can see in a specimen, this is the aortic opening, and here is the right coronary artery arising from the right aortic sinus, and this one is the left coronary artery. So, if we talk in detail about the right coronary artery, right coronary artery, as we previously discussed, that it arises from the right aortic sinus of ascending aorta. It passes to the right side of the pulmonary trunk between the right auricle and pulmonary trunk, and it then enters the coronary sulcus. The coronary sulcus is the sulcus that is also called atrioventricular groove or sulcus, which separates atria from the ventricles. Near its origin, right coronary artery, you can see it gives off an ascending branch, that is the SA nodal branch, which supplies the SA node. This is the SA node located near the superior vena cava opening, just at the upper extremity of the sulcus terminalis, or internally crista terminalis. So first branch is the SA nodal branch, then right coronary artery descends in the coronary sulcus, and then when it reaches the margin, right margin, it gives the right marginal artery, which supplies the right border of heart as it runs towards the apex of the heart. After giving this branch, right coronary artery turns to the left. Here you can see it turns to the left and continues in the coronary sulcus posteriorly. Here you can see it comes posteriorly in the coronary sulcus. Now at the posterior aspect, right coronary artery, it gives another branch to AV node, that is also located in the right atrium inferiorly, and AV nodal branch is given by right coronary artery from the posterior aspect, and it supplies the AV node. Then the right coronary artery, it gives in most of the cases posterior interventricular branch, which runs in the posterior interventricular groove, and this artery, as you know, is responsible for the dominance of heart if it arises from the right coronary artery. the heart is said to be right dominant, and if it comes from the left coronary artery, heart is said to be left dominant. Now, this posterior interventricular artery in the posterior interventricular groove, it gives rise to perforating branches. These are the perforating interventricular septal branches, which supply the posterior 1/3 of interventricular septum. So the branches of right coronary artery include SA nodal branch, which supplies the SA node. Then, during its descent, it gives rise to atrial branches, which supply the anterior and lateral aspect of right atrium. Then the right conus artery. It is another important branch which supplies the anterior surface of infundibulum of right ventricle, which you know is the upper smooth outflow part of the right ventricle, just approaching the pulmonary trunk. That is called the infundibulum or conus arteriosus. So that conus or infundibulum is supplied by right coronary arteries branch, that is the right conus artery. Then other branches are the anterior ventricular branches. These are the anterior ventricular branches. They supply the anterior surface of right ventricle. Then, as we discussed earlier, right marginal branch, which follows the lower margin of costal surface to reach the apex. And this is the marginal artery which is accompanied by the small cardiac vein. And then the posterior interventricular artery posteriorly in the posterior interventricular groove and the AV nodal branch. So, area of heart supplied by right coronary artery is right atrium, most of the right ventricle, as seen in yellow color. This is the distribution of right coronary artery. So, right coronary artery supplies the right atrium, most of the right ventricle, and part of the left ventricle. Which part? Mostly it is the inferior diaphragmatic surface. Then the posterior 1/3 of the IV septum, interventricular septum. Then in 60% of individuals, SA nodal branch is given by the right coronary artery, and in 80% of cases, AV nodal branch comes from the right coronary artery. Now the left coronary artery. Left coronary artery, as we know, it arises from the left aortic sinus of the ascending aorta. Now it emerges between the left auricle and the left side of the pulmonary trunk, in between pulmonary trunk and left auricle. Then it again enters the coronary sinus, and at the superior end of this anterior interventricular groove, just emerging in between the pulmonary trunk and left auricle, it gives rise to two main branches. That is the left anterior descending artery, that is LAD, that is anterior interventricular artery, which runs in the anterior interventricular groove, and second one is the circumflex artery. So in 40% of the cases, SA nodal branch arises from the circumflex branch of left coronary artery and ascends on the posterior surface of left atrium to the SA node. So this is the first branch which comes from the left coronary artery, which is actually a branch of circumflex artery in 40% of cases. As we know, 60% of cases it arises from the right coronary artery. Then if we discuss about the anterior interventricular artery, it passes along the interventricular groove to the apex of the heart. And here it is accompanied by the great cardiac vein. Now at the apex, it turns around the inferior border of the heart and commonly anastomosis with the posterior interventricular branch of right coronary artery. But we know that these arteries are functionally end arteries. This artery supplies the adjacent part of both the ventricles as it runs in the interventricular groove, and via its septal branches, it supplies anterior 2/3 of interventricular septum. As we know, posterior 1/3 is supplied by the right coronary artery. And in many people, the anterior interventricular branch, this branch which descends in the interventricular groove anteriorly, it gives diagonal artery, which descends on the anterior surface of heart. Then the circumflex artery. Circumflex artery, as you can see here, this is LAD and this is the circumflex artery. It follows the coronary sulcus around the left border of the heart to the posterior surface of the heart. The left marginal branch of the circumflex artery, it follows the left margin of the heart and supplies the left ventricle. So this is the right marginal artery and this is the left marginal artery. Then the circumflex branch of left coronary artery terminates posteriorly in the coronary sulcus. In 1/3 of the cases, it continues to give posterior interventricular artery. In that case, the heart will be called left dominant. So, left coronary artery, larger of the two, arises from the left posterior aortic sinus or left aortic sinus. In the left AV groove, it divides into anterior interventricular artery and circumflex branch. Anterior interventricular artery, that is the most commonly occluded artery, the LAD, left anterior descending artery. It runs downwards in the anterior interventricular groove to the apex of the heart and it supplies the right and left ventricles, and it is the artery which gives septal branches to anterior 2/3 of interventricular septum. Then it gives the left conus artery. Again, it supplies the pulmonary conus, which is also supplied by the right conus artery from the right coronary artery. Then the circumflex artery, it winds around the left margin of the heart in the AV groove, goes posteriorly. Before that, it gives the left marginal branch. Then anterior and posterior ventricular branches, they supply the left ventricle anteriorly and posteriorly respectively. Then the atrial branches are given posteriorly, which supply the left atrium posteriorly. So the area of supply of left ventricle is in this purple color by the left anterior descending artery and blue by the left marginal artery, and left circumflex artery posteriorly supplies the posterior aspect, that is the left atrium. It is shown in red. So left coronary artery supplies the left atrium, most of the left ventricle, part of the right ventricle, anterior 2/3 of the interventricular septum, AV bundle, SA node in 40% of cases, and AV node also in 20% of cases. So, as we discussed earlier, you can see here, this is the posterior interventricular artery. Dominance of heart is defined by which artery gives rise to posterior interventricular branch, that is the posterior descending artery. If this branch, this posterior interventricular artery, comes from the right coronary artery, it is called right dominance of heart. It occurs in 67% of the cases. And if it comes from this is the left coronary artery, if it comes from the circumflex branch of the left coronary artery, it is called left dominance of heart and it occurs in 15% of individuals. And here you can see both right and left coronary arteries, they contribute to this branch, that is the posterior interventricular artery, and now this is called the codominance of heart, which is seen in 18% of cases. So as we know that conducting system in the heart consists of SA node, AV node, bundle of His, right and left bundle branches, and Purkinje fibers. So the SA node and AV node are supplied by the right coronary arteries, bundled by the left coronary artery with contribution from right, and the right bundle branch is supplied by the left coronary artery while the left bundle branch is supplied by both right and left coronary arteries. So if we touch the coronary lymphatics, the lymphatic vessels of heart, they follow the coronary arteries and drain mainly into the brachiocephalic nodes anterior to the brachiocephalic veins and into the tracheobronchial lymph nodes, which are situated at the inferior end of trachea. So there is a clinical importance of these coronary arteries. There is a term called atherosclerosis, in which there is restriction of blood flow to the myocardium by narrowing and hardening of coronary arterial walls, and which is due to the buildup of cholesterol and fat deposits called the plaques in the coronary arteries. And this is called atherosclerosis, which could be partial or could be complete. So, what is myocardial infarction? If there is sudden occlusion of major artery by an embolus, the region of myocardium supplied by occluded vessel becomes infarcted and undergoes necrosis. And we know that infarction is an irreversible process. So the three most common sites of coronary artery occlusion are anterior interventricular artery, that is LAD, which is a branch of left coronary artery in 40 to 50% cases. Then comes the right coronary artery, 30 to 40%. Then comes the circumflex branch of left coronary artery, which is occluded in 15 to 20% of the cases. Another term is angina pectoris. It is a form of heart disease in which there is not a complete blockade of the flow, there is partial blockade, giving rise to inadequate blood flow to small area of heart, and it could be relieved by rest or sublingual nitrates, and its duration is less 1 to 2 or 3 or up till 10 minutes, and there is localized pain, some dyspnea, and pain could radiate to the left arm or jaw or neck. So functionally end arteries, we know coronary arteries are functionally end arteries. If there is sudden blockade of coronary artery, this anastomosis would not work between the coronary arteries, as there is no collateral circulation developed. So there is inadequate perfusion of myocardium, leading to ischemia and then the infarction, and resulting in myocardial infarction, which is commonly known as heart attack. And on sudden blockade of large coronary branch, some infarction is probably inevitable, but the extent of area damaged depends upon the degree of development of collateral anastomotic channels. So here you can see the angiogram. Coronary arteries can be visualized with coronary arteriograms. A long narrow catheter is passed into the ascending aorta via the femoral artery in the inguinal region. Under fluoroscopic control, the tip of catheter is placed just inside the opening of a coronary artery, and a small injection of radiopaque contrast material is made, and radiographs are taken to show the lumen of arteries and its branches. Now, in this picture, you can see a stenotic area, which shows the blockade. Cabbage coronary artery bypass grafting is done to bypass the obstruction of coronary circulation, and a segment of artery or vein is connected to the ascending aorta or to the proximal part of coronary artery, and then to the coronary artery distal to stenosis. Normally, great saphenous vein is taken for this purpose, and recently radial artery and internal thoracic arteries are also used for this purpose. So this was all about the coronary circulation of heart. Thank you.